I'm your host, Dale Sherbeck, and welcome to the HQ podcast. For those tuning in for the first time, the HQ is a podcast serial produced by CHA Learning and is your trusted source for important conversations on healthcare issues and topics from those that are leading and impacting the health system. Together, we'll explore these topics as we continue to learn together. CHA Learning is the professional development division of HealthCareCAN and is uniquely Canada's only national fully online learning provider serving all of healthcare. So please check out more about our learning programs and services after this episode and discover how we collaborate with health leaders and organizations like those we feature on the HQ to empower healthcare professionals with the knowledge, skills, and relationships to impact health system improvement. Thank you, listeners, for joining me today for what will be another amazing conversation. So after 2.5 seasons and this, our 54th episode, we have covered a whole lot of ground as it relates to the people who make up and deliver our health system. And not surprisingly, launching when we did, so much of our conversation has revolved around the state of our health workforce and what we can do to both ameliorate the situation and transform our system so that it can better care for our healthcare people and those served by the system. And so while much has been done and much continues to be done, much also continues to be discussed and a whole lot more remains to be started and done. By our research we've conducted with our members, vacancies remain high, in part because we have added many more positions in response to massive investments that are responding to massive healthcare needs. Turnover may have plateaued, but it also remains high. And coupled with a high degree of internal churn within organizations, it remains clear that we can't recruit ourselves out of this situation and we can't turn the talent tap on any faster. So clearly, much of our attention continues to focus on retention and all the critical inputs that will foster this, including the health, wellness, and safety of a workforce that was overstretched long before COVID was even a word. No matter your role or what part of the country you live and work, we have undoubtedly seen and heard from the governments and organizations and leaders all attempting to add their voices to tackling these issues. Unquestionably, though, there are few more exciting voices than Canada's Chief Nursing Officer Leigh Chapman, who was named to her role almost 2 years ago to the day as I'm about to have this conversation. Dr. Leigh Chapman is committed to advancing the nursing profession in Canada to ensure equitable access to quality care. As CNO for Canada, she provides strategic advice to Health Canada, plays a convening role on key nursing issues, and represents the federal government at public forums. Leigh is a registered nurse, or RN, who received her PhD from the University of Toronto St. Lawrence S. Bloomberg Faculty of Nursing. Over the past 20 years, she has gained a deep understanding of nursing by working both in frontline and clinical leadership capacities. In addition to her role as CNO for Canada, Leigh continues to work as a community-based consumption and treatment site in Toronto, where she provides harm reduction services and frontline care. So hi Leigh, welcome to the HQ, and it's a tremendous privilege to be able to have this fireside chat with you today around our health system and what can and needs to be done to make critical improvements in it.
Good morning. Hi, how are you? Really, really pleased to be here.
Thank you. I want to say happy anniversary too, on 2 years.
My CNO anniversary.
Yeah. So maybe with that, Leigh, I'm wondering if we can begin with a controversial question. Crisis or no crisis? I think as we've probably have both heard from leaders within the system over the last little bit, I think there's a growing desire to move away from the language of an HHR crisis and to focus instead on solutions. What do you think about that in terms of, do we keep calling this a crisis or focus on the solution side of things?
Well, this is one of those, both and question or both and responses, because I think when I started in the role in 2022, it was very clear that nurses and frontline providers needed to hear the word crisis, that they actually felt gaslit when we weren't actually talking about crisis because of everything that had been endured over the course of the pandemic. And I think there's validation in sort of calling it what it is, calling it what it was, because it was very, very difficult. And I know we talked about, doing unprecedented things in the pandemic, and that needs to be acknowledged. That it was an unveiling in COVID, that we were doing things we hadn't done before. We were pivoting in a way. We were being, forced to be nimble and agile and responsive. And I think during the pandemic, during those first, I would say, 3 years of the pandemic, there was a reticence to actually call it a crisis because we needed to just survive
Hmm.
what we were enduring in the COVID, in the peak of those first few waves of the pandemic. And I think that, when we weren't calling it a crisis, it really undermined the experiences of all of those who had been through such terrible times. I think that, fast forward now 2 years later, I would say that we are, reaching a new normal in healthcare. And so while we still have COVID among us, well, we have monkeypox just being declared an epidemic last week. We have certainly global health emergencies that are impacting and constraining our health systems. But we absolutely need to focus on the solutions. And the time is really ripe for solutions, as you said in the intro, that there's a record investment in healthcare. And I think that providers want to move beyond the crisis. They want it to have been acknowledged,
Yeah.
but they certainly want to move beyond and find some durable solutions. So that's really the current present day challenge. That's the burning platform that faces us today. And I think that's really challenging because we're really tired, because of what has gone on. But I think what's exciting to me is the possibility to innovate and to find creative solutions amidst all of these continual challenges.
Okay. So, I mean, so what would you, I guess, how would you characterize those challenges? I mean, what are we facing? What are we trying to fix? If we acknowledge that the system is, has been in a crisis, that's the normal, right? So we have a problem. What is it? What is the issue that you see or from your vantage point?
Yeah, I mean, there's no question that we have HHR challenges, health workforce challenges. And I would say from a nursing perspective, those are global challenges. We have a global nursing shortage, and likely in our lifetime, we will not have enough nurses. So that actually forces us to rethink and innovate on models of care and innovate on different care providers. We have, a number of people, a large number of people in Canada without access to primary care. And, we can probably measure, directly the impact of that on emergency departments, on, other systems that are having to respond to the lack of preventative primary care. We have an obsessive acute care focus in our in our healthcare system, acute care bias, and that's really inherent in the way that our systems have been set up across the country. And not to say that we're going to ever eliminate the need for hospitals. We absolutely need hospitals to be fully functioning, but we
Yeah.
need to absolutely eliminate the burden on acute care by focusing on upstream, public health, community-based primary care, and so on. We have increasing, an aging population. We have increased chronicity, increased acuity that we're seeing. And that's really actually challenging all providers across the continuum to be able to provide care to a much sicker population than they have, I think, ever probably been trained to provide care for, and also ever provided care for in the past. And then, I'd be remiss if I didn't mention the overdose crisis, which is really constraining all of our health system, with 22 people dying every day in Canada, and those folks largely without access to adequate services across the country. So, it is really a perfect storm. There's multiple challenges. There's no question, but I think I'm very optimistic that the opportunities outweigh the challenges that we're facing. These are not challenges that we can't overcome. We need lots of energy, we need investment, which we've seen, and we need the enthusiasm and the will really to innovate and be creative and find solutions that are actually going to move the needle on our health workforce issues and all the other issues.
Yeah, so I think if to summarize, I guess, we have increased demands, we have not enough people, we have a need to, I guess, look at the way our system itself is structured differently, um, and a compulsion, I guess, to sort of think creatively in all of that, while we have an exhausted workforce. So maybe building on that, I mean, there's certainly a lot of that focus on that transformation and innovation as you've just described. Um, Clearly, obviously, very necessary, but w- how is this going to impact our health workforce itself?
Oh, well, I think it is impacting the health workforce already. We have really a depleted workforce in terms of number, but also we have a workforce that is really, really challenged to deliver care. When you are trying to provide care in the way that you're competent and educated to provide care, and you're unable to do so day in, day out, it really does actually erode your sense of professionalism and creates great moral distress.
Hmm.
And for many, it's resulting in an exodus either out of the profession or certainly out of the public sector, publicly funded institutions into ways that work for them, whether it's travel nursing or private staffing agencies. There's lots of opportunities right now. And I think that unless we're finding those creative and innovative solutions in the public sector, we're seeing what's happening is that, people are either leaving the profession and sort of parlaying their health professions career into something else, or they're actually leaving the public sector.
Yeah, I think we certainly hear through other avenues, right, that we've got in some ways more physicians, as an example, in Canada than we've ever had. Um, but yet we keep talking about not having enough, primary care physicians or physicians in our hospitals or in other parts of the care continuum. So nursing, much the same, I guess, would you say, or?
Absolutely. We have more nurses now than we've ever had. And so, yet we have a nursing shortage. And so I think the challenge is always, how many are we short? We certainly have some data challenges in terms of figuring out, how many nurses do we actually need? How many are we short? Is that actually um, an achievable, number? Is it achievable to actually produce more nurses in Canada, to educate more nurses, or to encourage the integration of internationally educated nurses who may have chosen to come and join our workforce. Um, and I think that we need to be mindful of this from a global perspective. We have, almost 500,000 nurses in Canada, which seems like a really large number until you look at our geography.
Yeah.
But yet we have shortages of nurses and vacancies of nurses in almost every facility across the country. So really, it behooves us to think differently about the way that we're delivering care, and think about innovative models of how we can best use the finite health human resources that we have.
Fair. So, I mean, I know, trying to sort of make arrangements with you to have this conversation, you travel a lot and you talk to a lot of different organizations and leaders across the country, around the world even, and certainly to those who are working on the front lines themselves. Um, what are you hearing, I guess, from these different constituents, from citizens, from governments, from employers? What do you think that each of them wants from our healthcare system?
I think that I think that there's slight nuances, slight differences in terms of what they want or what they need. I would say the general public in Canada sort of sees healthcare like maple syrup, like something that is ubiquitous, that flows every year. That's something we can always find on our shelves, and it's kind of our Canadian fabric, in
Hmm.
terms of what we pride ourselves on. Maybe it's the Blue Jays, maybe it's poutine. I mean, you could use any other thing, but maple syrup is kind of the quintessential Canadian product. So we really do, I think, people in Canada really pride themselves on healthcare. But I think we also assume that it will be there. Care will be there when we need it. And when it's not there, it's something that we take, I think, very personally. I think there's a lack of awareness about what different providers do in the system in general. And I think we can go back to the banging on pots, for frontline workers during COVID. I think ultimately there's a fundamental lack of awareness about what nurses do, um, and really how autonomous nurses can be. And certainly in my travels across the country, I've been really inspired to see nurses in rural and remote communities really running the show, being really autonomously responsible for healthcare delivery. And I know there's many who say that, we need to move away from siloed practice, and we need to move towards team-based care, comprehensive team-based care. And I would absolutely agree, except that nurses are often filling in the gaps when in the absence of a team.
Hmm.
Nurses are often the ones really holding the fort, responsible for, care to entire communities when there are no other providers. And yes, there's interprofessional colleagues that are available virtually or at the end of a phone call, but it's really those nurses who are there at the point of care in communities, delivering round the clock care. And without those nurses, care to communities are completely curtailed. So, as the largest group of regulated health providers, nurses have a key role to play in the system. And I think the nurses want that recognition. And I think it's interesting because nurses are typically employees compared to physicians who, for the most part, are self-employed contractors. And so when we compare the two, it just is a really different way of valuing the work that they both do. And I think that we need to coalesce and come together and recognize that, the hierarchies need to be really flattened in healthcare, and in thinking about how to optimize the team and how to really optimize the workforce.
So I think is part. I mean, part of what you're describing as well is that I guess is that it's it's not a singular issue or problem, that looks the same in every part of the country, right? So, um, I mean, in Toronto where you reside, right, it looks perhaps different in terms of the way health nurses are employed within the acute part of the system. And then I think, as you would describe, going into rural, remote regions of our country, nurses' roles are going to be different then again. And so, I guess the question, about how do you create a resilient system that supports those different extremes, if it were to be described that way, is going to require perhaps different models or solutions. So, I mean, what would you think about that, or would be your wisdom to provide us?
Well, I think that's it, that urban centers can learn a lot from rural and remote parts of Canada. Like, obviously, rural and remote parts of Canada have a very nurse-led autonomous model, because of the duress of the human resource or health workforce challenges in those environments. But I also think that, as a way to increase access, even in urban centers, in large municipalities, we could be thinking about nurse-led models, about, nurse-led wound care clinics that are fairly autonomous, that, nurse prescribing hasn't been really optimized across the country. Yet we're seeing pharmacists prescribe, a great way to increase access. But nurses also have a tremendous amount of knowledge, skill, and judgment, and could be optimized to prescribe. So really sort of thinking of a whole of systems approach, instead of this sort of acute care, or urban rural divide, the acute care community divide, which seems to happen. We really need to think about integrating the system in a more coordinated way. I think that it may seem heretical to say that healthcare organizations shouldn't compete against each other, but that's exactly what's needed. They're competing for finite health human resources. Um, and I think that there's an opportunity for collaboration and sort of cross-pollination of resources, and 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 also integration with community, integration with home and community supports as a way of keeping people out of acute care, um, and really bolstering the supports in community, really having that cross-sectoral fluency to make it a lot more seamless. And I know that, the systems may not be set up as such across the country, but I think providers and organizations can actually look beyond their borders and find those opportunities for collaboration.
So what do you think is getting in the way of that? I mean, I think as you've described during the pandemic, we freely innovated. I mean, we had to. And I think, if I reflect back on, conversations 4 years ago, people were sort of thinking, well, I hope this is the new normal, that this ability to collaborate and innovate, that we won't go back to the way things were before. And I think, 4+ years now in, I think we're starting to see the pendulum swing back a little bit. So, I mean, what do you think is why is there so much that, I guess, if that rigidity, right, to doing things the same way always, and it's somehow expecting different results?
Yeah, I mean, COVID is a good example in many ways because it forced very quick strategic thinking. I think of some of the things that I was responsible for during COVID, and we were able to set up essentially a health system on a dime, things that would have taken months and, a pilot and a proof of concept and evaluation in regular times. And, setting up very, very quickly and being able to innovate, it forced that strategic thinking, and it forced sort of an all hands on deck approach, because we were anticipating, the calamities that were happening in Italy and even in New York, in Canada. And I think that we have gone back to status quo because it's about putting out fires. We've gone back to operational the operational fires that persists. And it's not to say that healthcare organizations aren't still being strategic. Of course they are. They have their strategic plans, and they're,
Hmm.
responsible to their governors, their board, and their funders. But I think that, we're so mired in the day-to-day operations of ensuring we don't have protracted surgical wait times, ensuring we're keeping emergency departments open, that it's very, very difficult to innovate. And so what ends up happening is that we have a slow drain, whether it's an internal churn of providers who aren't happy because their needs aren't being met, or we have folks who are, exiting the organization, and we just keep focusing on, okay, well, we have to fill that vacancy. We have to fill that vacancy. We're short providers in this unit. We have sick calls. We have to fill the sick calls. And I think those operational challenges trump strategy day in and day out. And so we go back to sort of cocooning into status quo, instead of actually reemerging in a different way and innovating. And it's not to say that, we're not going to it sounds very idealistic to say that we don't have to deal with those operational fires. We absolutely need to. We need to keep emergency departments open. We need to keep folks having surgery, and we need to fill vacancies and sick calls, but we also need to do things differently. And I think that's the challenge, that there's change fatigue. I think there's leadership challenges as well in healthcare. And, all of those things make us very mired in day-to-day operations instead of thinking about the art of the possible in terms of what we can do in healthcare in a different way. And it's those changes that are needed incrementally now to be able to respond to future health emergencies.
Hmm.
And I do worry that, we have gone back to our old way of doing things. And we're not going to be able to respond not only to the current health workforce challenges, but future health emergencies. And that's very concerning.
Maybe well, I don't want to put words in your mouth, but if part of what I'm hearing, I guess, is that in responding to some of the critical needs that we're facing, we are investing those resources and people into fighting those fires, effectively doing the same things that we've always done, as opposed to investing them, I guess, in innovative new ways to sort of get ahead of the curve, right? So we're really just sort of feeding the same cycle by bringing people back in to do the same things that we've always done, and there will probably never be enough resources to do so.
That's right. And I think, many healthcare executives have an overwhelming number of operational responsibilities that they are, completely hamstrung and unable to actually focus on strategy because the operational fires are so prevalent every day. And yeah, so I think it is sort of this perfect storm. We don't want to innovate because it's more resource intensive, it's more labor intensive, but that's actually what we need, is that creative thinking, that innovation. We, I think, have become very risk intolerant because COVID presented all the risks.
Hmm.
And so we've, as a almost a boomerang reaction, we've become very risk intolerant. And healthcare generally is risk intolerant. It should be risk intolerant. Um, but it's actually creating health workforce challenges that I think you can make a direct link between the health workforce challenges and quality and safety. So to be able to meet, the needs of those we're serving from a quality and safety perspective, we actually need to innovate. We need to actually have dedicated time for strategic thinking and innovation. And perhaps it's sort of having folks that will be putting out the fires and handling the operational responsibilities so that healthcare executives can actually focus on strategy, innovation, and that creativity. We don't often equate creativity with healthcare because it's so rules based in terms of meeting standards of practice and meeting legislative and regulatory requirements. But there's tremendous opportunity for creativity, and I've seen that in the myriad ways in which care is delivered across the country. All while meeting standards and all while meeting legislative and regulatory requirements. So that's what we need to do is lean into that creativity.
Yeah, well, I guess I find it interesting, and I just, the people that we select, I guess, for our healthcare professional programs, right? They tend to be very science-based focused, right? Math and science and problem solving, and the whole the scientific method approach to things. And then you talk about the need for creativity, and it's not that people who are scientists can't necessarily be creative, but they are, there are different personality types in that, right? And different skill sets. And I think if we overly select for a certain kind of skill set, does it not produce some of the results that we see?
Yeah, I think so for sure. Like that reductive sort of problem solving scientific approach. But I think we're one thing that I think is really inspirational is that we're attracting different folks into the health professions, whether it's late career um, uh, career changes, late career providers. When I think, my lens is nursing. So if it's late career nurses or
Hmm.
internationally educated nurses, um, and I think also the current generation of nurses want something completely different in the workforce. So there's opportunities to really learn. I think we also have to think about sort of the traditional approach to career development in healthcare were often those who are promoted to leadership positions or promoted because of their clinical competence and expertise, and they've, earned the trust of their colleagues on the unit. They don't often make the best leader. So really thinking about, leadership development in healthcare and who we can promote to those opportunities. We spend a lot of time telling learners, new graduates, and even internationally educated nurses all the things they don't know about our Canadian health systems, instead of actually thinking about what they bring and the gifts that they bring to our health professions and what we can learn from them. It requires, that openness and vulnerability, but I think that's absolutely the way we need to move towards.
So maybe we can just continue with that a little bit then around the role and the focus on leadership within the system. You've mentioned it several times in the last little bit here, both in terms of leadership development, that some of the challenges that we're facing with our executives and these needs for thinking differently. So what would, do you think we have a problem with leadership in healthcare? Is the problem of healthcare a function of a challenge with leadership itself, or where would you tease that part out?
I wouldn't say it's across the board a problem with leadership. I would say it's you can almost just pick it up the moment you set foot in a healthcare facility. It's very tangible and where the challenges are present. Um, but I wouldn't say it's across the board. There's some incredible leaders who are really, doing leadership in a completely different way. And I think, um, thinking about, um, representation in leadership as well
Hmm.
is really important from an equity, diversity, inclusion lens. We have, I mean, I'm very mindful of that in nursing, that we have a lot of white nursing leaders, and that's not reflective of the nursing workforce. That's a problem as well in nursing faculties. So things we need to actually think about and be intentional about. I'm very mindful of that in my role as federal chief nursing officer. So that means I really benefit from collaborative opportunities with Canadian Indigenous nurses, with Canadian Black Nurses Alliance, and other equity deserving groups. And I think there's organizations that are being intentional about leadership. There's very few um, female CEOs of healthcare facilities, very, very few across the country, and even fewer who are Black, Indigenous, people of color. And I mean, I think that is something that organizations need to look at in terms of, who's representing their workforce. But I think there are leaders who are really trying to lean into equity, lean into diversity, inclusion, and also learn into a different way of leadership. COVID, forced us to think about not just whether people were coming into work, but whether they had childcare, whether they had toilet paper, or whether they had groceries when everything was shut down. And that hasn't left us. We need to actually think about leadership from an anti-oppressive standpoint and, think about having difficult conversations. I've had some leaders say, well, I'm not, I don't have training in mental health to be able to actually meet the needs of my staff. But we're all people. And I think sometimes we forget that human connection
Hmm.
in caring for each other as workers. Like we're not bots in a factory. Where the whole premise of care and healthcare is about the relational aspects, caring for people. We have to care about the people we're serving, but we also have to care about our colleagues and have that trust. And I think when that's established, we can do anything.
Hmm.
But we forget that.
Yeah, I think it makes me reflect on, you know, um more modern sort of approaches to medicine where, the calls that physicians should treat the whole person, right? Not just the body or the illness that's in front of them. And I guess likening that to leaders should perhaps, lead the whole person, not just, right, the tasks in front of us.
Oh, absolutely. And not just, ensuring they come in for their 11.25 hours or their 7.5 hours. But yeah, treating the whole person. I think, back to your analogy on healthcare, we absolutely need to treat the whole person, but the system isn't designed as such. And so it creates this distress. And unless we have good collaborative relationships, we'll never get through it together, unless we're working together. We need to think about if somebody's coming in off the street into the emergency department, we need to be linking with a social worker. We need to be linking with community-based resources and really having the trust of our colleagues to all work together in knitting together the disparate parts of the system to meet the needs of the patient.
Yeah, so I think the operative word that you continue to use, right, is around that collaboration and working together. Whereas so many parts of the system are siloed, right, and so we operate in the sphere of what we're responsible for, and so I think as you've described, right, and we've heard through some of our own conversations with our members, which yes, our workforce needs support in daycare, or they need support in if they're new Canadians in new Canadian services or things like that. And yet it would be very easy to say, but that's not my job, right? To support these people in those ways. I'm not trained to do that. I'm not resourced for those things. They need to find those resources somewhere else, but they don't. And so then it becomes an employer's problem because those people can't come to work or can't be the best selves at work.
That's right. And I think that the best leaders are the ones who are resourceful. They don't have all the answers themselves, but they actually know where to go to and where to refer people, and even do that warm handover, that they're able to earn the trust of their staff, their colleagues, because they actually know they have that resourcefulness. And even if um, they're able to say, I don't really know, but let's find out together. I think it goes a long way towards recognizing the relational aspects of care, and the service provision that we're in. That's really the business that we're in. So if we don't like people, we're in the wrong business. But I think that needs to be really centered and foregrounded in everything that we do.
So I think, when we're having those kinds of conversations with our members, and I speak to HR executives, the conversation is largely going to focus on some part of the pipeline of talent, and things that we've already talked about during the course of our conversation. But how do you attract and get people into the sector, which includes everything from immigration to how do we help keep those people in the system once they arrive in our organizations, to things like equity, diversity, inclusion, anti-oppression, reconciliation, access, um, and the health and wellness of our workforce. And you've talked about models of care and how do we maximize our workforce, to make the best use of the people that we have. So how do you, I guess, how do you bring all that together? I mean, are these the right conversations that we need to be having? Is there something else that we should be talking about? Where does your office sort of start to move, some of these things forward?
Yeah, I mean, I think they're absolutely the right conversations, and they require bold, courageous, and vulnerable leaders. We need to recognize that leaders aren't impervious to all the challenges that providers face, and recognizing the human elements. So I think they're absolutely right, the right conversations. Really, I would say the the need to really focus on the like durable solutions to the existing workforce. I know you mentioned the pipeline, and I think there's always going to be a need to actually recruit and fill vacancies. But unless we're actually strategically shifting that focus to retention of the current workforce, I think we'll never get out of the endless cycle of recruitment. So, I mean, I think that's really where I've been trying to lean into the need to focus on nursing retention. It was very clear to me in the early days of my appointment through engagement with nurses across the country that they were really feeling left out of the recruitment incentives that were, bubbling up across the country, whether it was increased nursing education seats in almost every jurisdiction, or enhanced incentives,
Hmm.
recruitment bonuses, and also means of better integrating internationally educated nurses. And I think the existing workforce is sort of had been feeling like, what about solutions for me, and all of the time and investment that I've, you know, provided to the profession, but also to the organization. So that really, I think, it behooves us to think about nursing retention. And we released the nursing retention toolkit just in March of this year.
Yeah.
And but we did release the executive summary with just the themes and the initiatives in the fall during the federal, provincial, and territorial health ministers meeting, because we wanted their endorsement. And the ministers all agreed to support its dissemination and implementation, which I think is very promising, because we know it's not cost neutral. We know it requires a record investment in healthcare, yet we've also had a record investment of with all those bilateral agreements being signed. So we really are keen to see, how organizations are implementing the retention toolkit. It is there's no one size fits all approach within our health systems across the country, but I know many organizations have been really running with it and using it for strategic planning, using it as part of their nursing practice council, even using it cross-sectorally, I think, which is really exciting to see, how how a theme, for example, may be taken up in acute care, but then also in a community partner organization.
Yeah.
So I think there's, a variety of ways it can be implemented, but it does focus on, some of the things you mentioned, less so on the pipeline, less so on the recruitment piece. But that said, retention starts in nursing education programs, because when the service side of healthcare is strained, so too is the education delivery system. And we know that students don't get quality placements when they don't have happy preceptors who are and organizations that are willing to support their learning and have that dedicated time for learning. And, it's really hard to have a supernumerary learner in an environment where you have so many vacancies, but that's in fact what we need to do, is ensure that protected time for learning so that we're actually able to retain them in the profession, and hopefully in the organization as well. So we focus a lot in the toolkit on organizational mental health and wellness supports, on leadership, on management competencies, safe staffing frameworks, flexible and balanced ways of working. All of those things require innovation and creativity. So we're really keen to see how that's being taken up. We're canvassing organizations across the country right now to see, get any early wins and see, how they've been implementing the toolkit, because we want to have some data to feed back to the ministers this fall.
Yeah. Well, I think certainly from the conversations I've been having and hearing, right, it seems to be a huge amount of support and recognition of the great work that your office has done in producing the toolkit and starting to implement it. Um, I guess part of what when I reflect on reading through it myself and looking at the framework, a lot of it seems like you can expand that beyond nursing, right? To, these would be best practices, for lack of another term, that organizations should apply to, retaining their whole workforce. Are there thoughts and considerations or other conversations that you're having in terms of the utility of that across, the larger health workforce?
Yeah, absolutely. You're bang on. Like, in the territories, generally health and social services are combined, and so, you know, they would be remiss to implement something that was uni professional just for nurses, without inclusion of health and social services more broadly. And I think, it's very clear that nursing itself doesn't own retention. These are problems across professions.
Sure.
I think that there was a very strong spirit that the toolkit was echoing what nurses have been saying in the profession for some time. So with that, the notion of it being by and for nurses. But again, I think many of the themes in the toolkit are generalizable across the health professions writ large. So yeah, I think it is a choose your own adventure, a toolkit. We think that organizations can take it up. And many of those, I said nursing practice councils, but many of those practice councils are also interprofessional. And so it's a way of sort of looking at the toolkit and saying, how could this be implemented across several professions? Where's the most what makes most sense to focus on strategically within an organization from an interprofessional standpoint. So I think lots of opportunities in the toolkit, but yeah, nursing sadly doesn't own, well, no, actually, fortunately, it's not, retention isn't just a nursing phenomenon, it is across the board.
Yeah, well, and I think anything that's been taught to us over the last uh, few years now, right, is that you take, we work within a system and you take any one part of that system out, no matter whether it's the, nurses or, you know, uh, another sort of subspecialty or certain one-offs within that, right? The system doesn't work as well, or it creates these massive bottlenecks where we least expect them. So I guess, what are you, maybe just to share any clear examples or wins that you have heard that would certainly excite people to sort of explore the toolkit more in more detail.
Sure. I mean, one thing I was just going to mention around what you said is that you're right that it is an interprofessional challenge, and that I think that one of the reactions I often get from um, healthcare leaders is, well, why nurses? Like, I can't just focus on nurses. I have to focus on the interprofessional workforce. And I think that's fine, but I think unless we fix nursing, we're going to have bigger challenges. Nursing is
Uh,
the largest group and is often most proximal to the point of care. So it is, often nurses as individuals who are blamed for many of the structural and systemic challenges when emergency departments are closed or when ORs are curtailed. So, there is, I think, strategic value to actually focusing on nursing, and not to say that the other professions aren't just as important, but nursing does have some unique challenges as well. Not that retention is a nursing phenomenon alone. In terms of some of the things early wins, I would say, one of the things we put in the toolkit, which, was somewhat controversial for a Government of Canada document, was that we talked about daycare for shift workers and the provision of daycare. We have a largely feminized nursing workforce in
mhm.
particular, yet we haven't actually figured out, daycare for those who are on call or working overnight and so on. And so we've actually, we provide some examples of existing organizations that have. It's not to say that healthcare organizations should have a daycare provider, within their existing real estate or as part of their bricks and mortar site, but just having those collaborative partnerships. So we've seen a daycare for shift workers, a daycare open at Newfoundland with dedicated seats for shift workers, which I think is really,
Mhm.
really exciting. And again, not just for nursing, for, physicians have to work, all providers need to work around the clock in the 24/7 endeavor of healthcare. Um, I often use the example of the Manitoba Shared Services Provincial Float Pool. So it's a really exciting, I think, opportunity where they created essentially a provincial float pool within the existing provincial health authority. So nurses could work, for example, at Winnipeg Health Sciences, but then also go and work in a smaller community hospital just outside of Winnipeg, have their travel and accommodation paid, but still be part of the public health authority. And they've seen, in fact, To me, this is just such a promising model because it provides nurses the flexibility that they want and some variety in their practice. It enriches their practice and I think enriches the practice of their colleagues. And they've seen nurses actually come back from private staffing agencies to work as part of this provincial float pool. So, required some innovation and some investment, and obviously a collaboration with the union and with the health authority and government partners. But I think a really promising example. Um, there is some work underway within the Toronto Academic Health Sciences Network, which is a whole conglomerate of academic health sciences hospitals in Toronto, to actually look at cross-organizational implementation of the nursing retention toolkit. And that's just exactly what we need to see, that
Yeah.
regional approach that again, eliminating competition for finite resources, but really thinking about where are the opportunities for collaboration across the system. So those are, I mean, just a few examples, but as I say, we've cast the net to sort of try to get some of those early wins, but also to get the misses, right? If there's organizations or jurisdictions that are saying, no, we're not implementing the nursing retention toolkit, we have our own approach. We want to learn what that approach is. I know there's some jurisdictions that are sort of on hold because they're waiting, some of the recommendations in the toolkit probably have implications when it comes to bargaining. And so they're waiting for the right moment to actually look at, when they can look at some of the themes in the toolkit and having provisions in the collective bargaining agreement that would allow for the implementation of some of the initiatives. So a bit of a mixed bag, but we're really interested to hear from organizations across the country.
Yeah. Thanks for sharing those, Leigh. I mean, I guess that some of the opportunities and challenges, right, are on those sort of fixed structures and processes that we have within our systems about how people work. You talked about like shift work, or, you know, you're an ER nurse and then that's what you do. And it's I think as we've obviously heard, a high stress environment. And then people want to sort of be able to leave that. But I think in some of the examples that I've heard, and even your float pool sort of example allows people to cycle out of that for a period of time, and catch their breath, so to speak, without being lost entirely to, that specialty. So, I mean, are those sorts of the examples of like the innovation when we talk about innovation and models of care, of sort of allowing people to work differently that sort of supports them where they live and work, so to speak, but also serves the system more broadly speaking?
Yeah, absolutely. I think there's I think there's more similarities in the system than dissimilarities. And so thinking about, how we can leverage whether it's sort of a decompression time, or flexible scheduling time, even as a learning opportunity for others. I think that healthcare providers were our own worst enemies. We pick up overtime. We, take financial incentives instead of actually taking time off. But we absolutely need that time off. And more nurses and other providers are actually saying they need the flexibility, and it enriches their practice. And one example I would say is, late career nurse initiatives across the country, how they've been implemented even in the absence of provincial or territorial funding. There's some organizations, a couple of examples come to mind. The Ottawa Hospital has done a great job of this, as well as St. Paul's Hospital in Vancouver, and where they've brought back late career nurses, brought them, we had a record investment or record number of late career nurses come back and help with screening and vaccine efforts
Hmm.
and so on during the pandemic. So they've brought them back, offered them some coaching expertise, and they're actually able to provide that at the elbow support for new nurses. And they absolutely love it. Many have said that it's the most rewarding thing they've ever done in their career. They
Oh.
don't have all the answers,
Hmm.
but they're able to work together. And they love the fact that they're not, responsible for direct care provision, but they're actually able to be a resource and tap into all of their vast expertise. So, finding examples like that, I think with the multi-generational workforce that we have, we need to find those examples.
Hmm. Wonderful. Very inspiring. Um, so, what's next for you, Leigh, and the Office of Canada's Chief Nursing Officer?
Well, we are looking at, sort of an impact assessment of the toolkit to see what difference it made. It was a huge liftoff to get the toolkit out within, I guess, about a year and a half of my tenure. That is lightning speed for government, I'll have you know.
Hmm.
So we're really curious to see, how what difference it made. Looking at the analysis of implementation, which I think is really key for a strategic initiative, a strategic tool or resource like this. I'm really excited to also be working on an Indigenous companion guide to the nursing retention toolkit, because we knew when we were creating the toolkit, although we had phenomenal in involvement of Indigenous nurses across the country, we knew that we were missing the retention piece,
Hmm.
and some of the structural barriers that exist for nursing for Indigenous nurses. So I'm really excited about that because I think it will, I think Indigenous nurses in particular have felt extremely left out of all of the investments and initiatives for internationally educated nurses.
Hmm.
And so I think that'll be a way to sort of shift our gaze in that direction of looking at how underrepresented Indigenous nurses are in our nursing workforce and um, how we can bolster their involvement in the nursing profession
That's great.
through recruitment and retention initiatives. And then, internationally educated nurses is still a really important priority. So, looking at how we can harmonize some of the requirements for internationally educated nurses across the country. We're finding, I would say that's it's the fastest moving file that I'm working on. Across the country, it's really hard to keep pace with the changes that are happening at the jurisdictional level. But what's happening is there's actually a lot of interjurisdictional poaching or competition for talent that's happening,
Yeah.
which I think doesn't serve us overall in Canada. And it certainly is very confusing, I think, to the internationally educated nurse who chooses Canada as a nation, as a country. Um, and so really looking at how we can harmonize those requirements for internationally educated nurses across the country. So yeah, lots of work. No, never a dull moment. But I wouldn't have it any other way.
Well, it's important work, right? And I think in terms of the next steps that you've just described, I mean, both of those um, prioritizations, I think will go a long ways, obviously, to changing the face of healthcare, the face of our workforce. Bring that diversity into our workforce, which will probably foster some of that creativity and innovations, and better serve the communities, right, that are also under uh, represented in our healthcare system itself. So
That's right. Yeah, I mean, back to the maple syrup analogy, that there's not a single person in Canada that won't have some interaction with a nurse and with our health system in their lifetime. And I think we need to be really mindful of that when we think about creating the system of the future that will respond to our needs selfishly, when we are in need of care provision and we're recipients of care.
yeah,
We need to really engineer the system to meet the needs of everyone in Canada. And unless we're doing so, we're going to continue to face these wicked issues, these challenges, and yeah, so I think again, lots of opportunities, but we need to be bold and courageous.
yeah, good words. we could end there, but I will give you the final moment just to sort of any other final words as we end off here, Leigh.
I mean, I would just reiterate that healthcare is, we're in the business of serving people, and it really is legacy work that we get to do every day in healthcare. It is a small miracle when we are able to, when babies are born healthy, when folks get adequate wound care and they don't end up on IV antibiotics, when they have a surgery without complications, or when they have a peaceful death. And these are all, small miracles, and really, we're impacting people's lives every single day. So I think that's something that we need to keep in mind, regardless of our role in healthcare, whether we're in policy, like me, or whether we're at the point of care on the front line, or whether we're in executive offices. These are things we need to keep in mind, and that it is relational. It's the system is engineered to be relational. And so we actually need to respond to the needs of people, our workers, and the providers that we serve. And I think that when we center the needs of those we're serving, and the providers who are providing care, we make really good decisions and help. So that's maybe good.
Yeah, well, I mean, I know you have brought compassion and care to all parts of your work before you entered as the chief nursing officer. But I think it's a huge part of who you are today as well in terms of your role. And I hope in terms of impact and influence that you will both influence others to join the profession and our health workforce, and those that are here to continue to have hope and to stay and to continue to fight to innovate and improve our system with you. So thank you.
Thanks so much, Dale. I've really enjoyed the conversation.
Thanks. Take care.
Thanks, you too.
You've been listening to the HQ, and I'm Dale Sherbeck, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.